Okay, so now we have our setup at our clinically determined vertical dimension of occlusion. Because we're not going to be scanning for surgical guides in the top, I can do my setup. I can remove the teeth from the upper model, and I can, by using the photos that I've taken, set my teeth in the proper position so that I can determine where the midline is going to be, what the incisal edge position is going to be. I can control all of these factors so that I can use this to make an immediate denture. And also, I can set up the lower teeth, the lower posterior teeth, because I don't like fabricating dentures to air. And we're using the anatomical landmarks like the retromolar pads, putting those posterior teeth 2/3 up the retromolar pad. And now I can send these models to the laboratory so that they can scan for a lower surgical guide and have all the information that I've determined in terms of the incisal edge position, the plane of occlusion, in order to fabricate a proper prosthesis. So we're going to send the models to the lab. They're going to place these models in a lab scanner. And they're going to scan the lower model with the setup. And then they're going to scan the lower model without the setup. And they're going to scan that lower model without the setup because our surgical guide is going to have to fit those teeth and fit the ridges perfectly in order to fabricate that surgical guide. It's very important that during all the procedures we've done, setting up the teeth, that we leave those lower teeth untouched, no chipping of the teeth, because if the surgical guide doesn't fit properly, then we've wasted our time and we're not going to be able to use the guide at the time of surgery. Now the lab can merge these STL files from the scanner with the CBCT, and we can place it in a software to do our surgical planning and our guide fabrication. In this case, it was Co-Diagnostics by Straumann. And because we have all of those tooth positions predetermined, this implant planning is going to be prosthetically driven. And now we can fabricate our surgical guide. So once we've had a meeting and we've approved the implant positions and everybody's okay with the plan, the laboratory is going to send us a summary of each implant position so we can look at it from different views, look at the implants in relation to each other. If there's any changes that we would like to make, we can still do them at this time. And now we can approve that plan and then have the lab fabricate the surgical guide. The information that we get from these plans is the proposed implant positions, any anatomical limitations. We can measure the restorative space. We can measure the amount of bone reduction needed. And we can determine the cuff heights and the angles of the SRA or MUA abutments. They're going to give us a detailed summary of everything we need, the reference numbers, so that we're not missing something on the day of surgery. From the implants to the sleeves that are placed in the guide to the MUA abutments. And they're also going to give the surgeon a menu that outlines the steps during the surgery. That goes from drill to drill, tells us what spoons to use during the surgical guide, the depth of the osteotomies, and the timing that we need to put those angled MUAs in the proper positions. So as I said, the upper arch allow immediate implant placement. So we're going to fabricate an upper denture. The lower arch will be surgically guided and 4 implants will be placed. And because of the patient's anatomy, because of the lack of bone, and because of the fact that we're going to have to take away that anterior bone, we're going to try to encourage the patient to consider a fixed option. And the reason I felt that way is because I was afraid with an immediate denture and with the little bone and with the floor of the mouth being so high that this immediate denture would not have good stability. It would be moving around on that surgical site, possibly affecting the healing of the implants, possibly tearing up the sutures. So I wanted to try to give her, again, the option of having of leaving that surgery with a screwed-in prosthesis to be kinder to the underlying tissue. Even though the patient understood that from a financial standpoint, she still couldn't afford to do that. And so she still was insisting on moving forward with 4 implant snap-on overdentures in both arches. Here you can see again my concerns about the posterior ridge being so low and the floor of the mouth actually being higher than the ridges and the lack of attached tissue. So between myself and the surgeon, out of the kindness of our hearts, we decided that we were going to just do a screw retain immediate load prosthesis on the day of surgery to help and protect that surgical site. And I want to talk about why I think guided surgery is so important. Because it allows us to have parallelism of the implants, and you'll see that with LOCATOR Fixed, this is very important. It allows us to maximize the AP spread. It gives us ideal bone reduction. And it allows us to put the implants within the confines of the planned tooth positions. Now you can see in this picture, the planned implant positions are lingual to where the lower incisors are. And that's because, as you remember, those lower anteriors are splayed, and that's not the position that we want her ultimate teeth to be in. So by having a digital workup and a digital design, we can predict where those lower incisors will be and put the implants in the proper position and not according to where the teeth are at this time. So now that we have our model scan, now I can cut these teeth off of the lower master model and complete my setup so that I can fabricate this lower IVO-based processed immediate denture. And we're going to ultimately use this denture to do a immediate load conversion at the time of surgery. And in this case, we're going to use what's called a smart conversion, which is a really unique and simple way to do these conversions without having to put these big holes in the denture that can weaken the denture and make it more prone to fracture during healing. Here's our upper immediate denture, also processed in IVO base. When we seat this denture, we're going to be relieving the inside of that prosthetic where the areas of the bone grafting, so we're not putting pressure on that bone grafting. And here's our post-surgical Panorex. And you can see how we would be placing our MUA abutments with angled abutments in the distal and picking up our prosthesis using that smart conversion technique. And the way that it works is we use these screws that have a very weak juncture between the head of the screw and the screw itself. So these screws hold in the abutments that connect to the SRA abutments. And once the material sets by placing little wells in the intaglio of the denture, once it sets, we can just basically pop that denture off. The screw breaks away from the head, and then we can simply remove the little screws from the MUAs, and then in the intaglio of the denture, we're going to drill through the intaglio, making nice tiny little screw holes for the screws to be able to connect to the MUAs at the time of delivery. In the upper denture, we're going to place Linol to stabilize that. And so here's our conversion prosthesis delivered on the day of surgery. 3 months after surgery, the implants are healed fine. The patient loves having that lower fixed prosthesis, but she continues to decline a screw retain type of prosthesis. And it was about that time that Straumann approached me along with Zest about trying out the LOCATOR Fixed. And because I was able to do this at a decreased fee, the patient was more willing to accept that fee, and so she agreed to proceed with the LOCATOR Fixed on the lower. So now we do our border molding, take our final impressions, and here's our maxillary final cast, because we're going to make her a new denture so that she has something really nice against her LOCATOR Fixed while those upper implants are healing. And we also take a mandibular preliminary impression using a closed tray technique. Now, because ultimately we're going to pick up our processing housings on the model in the laboratory, we have to have a very highly accurate, verified master cast. And we know that with conventional closed tray impression copings, we don't really get the quality and the accuracy of the master cast. So this is used as a preliminary impression. And on that preliminary impression, we're going to make what's called an impression jig. We do this with Duralay, and because Duralay shrinks while it's setting, it's going to create some inaccuracies, so we can't just transfer this to the mouth to take the impression. So what we do is we cut through the impression jig, and then we're going to deliver each of these sections of the jig in the mouth and then connect them in the mouth with a little bit of Duralay. And so that's going to decrease the shrinkage and give us a very passive impression jig. We fabricate a custom tray over that impression jig so we can have equal amounts of materials and also improve the accuracy of the cast. And for this technique, I like to use light-bodied Identium from Kettenbach to inject underneath the jig. And then my assistant will be placing medium viscosity in the tray. The jig is going to go, the custom tray is going to go over the jig. The screw holes will be sticking out the top, and then we'll be able to unscrew this impression, remove the impression with the jig inside of it. So now we have our master cast with highly accurate implant sites that exactly duplicate the position of the implants in the mouth. And on the right, we see our border molded upper master model. Now we can measure the tissue heights on the master model, select the proper height abutments, and then we're going to screw them into the model at 25 Newton centimeters. On this model, we're going to fabricate base plates and wax rims. We're going to go to the mouth. We're going to take an upper face bow. We're going to do a bite registration at the proper vertical dimension. And then we're going to mount those models and complete a setup. Now, when I went to have my try-in of my setup, I saw that my bite was off. And really the reason why it was off was because the lower base plate, because of that flat jaw, was not stable enough to get a proper and accurate bite registration. So what I did was I took this to the lab. I placed a few housings on the distal implants, and then I blocked out the anterior abutments so that I wouldn't lock my base plate onto the model. Reamed out the inside of the base plate a little bit, and then injected some chair side pickup, picked up those housings on the model. And what I've done is I've created a stabilized base plate. So when I take a new bite registration, I'm going to get a much more accurate bite. So here's our stabilized base plate. We go back to the clinic, we take a bite registration, now we have an accurate mounting. Now I can complete my setups in order to have a final aesthetic try-in. Here's our setups completed. A couple different views. And now we go to the mouth. We check our bite, we're dead on. The patient's happy with the aesthetics. I was kind of the feeling she could show a little more tooth. So before we process this, we were going to make some adjustments to give her just a little better show, a little better aesthetics. Now here's that example of how I like to evaluate my restorative space before processing anything. So here's the setups. Here's a little putty matrix that shows me where the teeth are. And then when I remove that base plate, I can look at the vertical height. I can look at the restorative space and make sure that everything is going to work in terms of the materials that I'm going to use and have a nice strong prosthetic that's going to give us a nice long-lasting result. And we can take off the lower and look at our restorative space in relation to the upper. And we could do the same with the lower. And the reason we want to do this is because, as you can see here, at the vertical dimension, I've determined the retromolar area is in contact with my upper model, which isn't going to give me enough space for my base plate, for my maxillary immediate denture, because if the patient closes and hits that acrylic, it's going to tip the denture or open the vertical. And so now I know that I need to ask my surgeon to do a little bit of a tissue surgery. And I send for a maxillary tuberosity reduction at the time that the surgeon is going to place the implants, because now the upper bone graft is healed. And so while he's in there placing the implants, I could ask him for a little more space for my denture base. Now I'm going to go through this work authorization because a lot of times I think some of the problems we have are from lack of communication from the lab. So as I send this in, what I say to my lab is, please scan the mandibular setup and design a locator fixed prosthesis. Measure the AP spread and make sure that the distal extensions are no further than 1 times the AP spread. Design struts extending from the prosthetic to the land area on both buccal and lingual to allow precise positioning of the prosthetic when I'm picking up the locator fixed housings. So you'll see what these struts are, but this is going to allow us to do the pickup of the prosthesis in the exact same position as the setup. And that'll become clearer as you see the following slides.